Good evening, everybody, and I would like to welcome you all in tonight's webinar. Tonight's webinar is a part of an extended course, 3 parts. This is part 1 about PEF or heart failure with preserved ejection fraction. As you know, this course is arranged by EAVA Society and Novartis Company, and by EAVA is a symbol of Egyptian Association of Vascular Biology and Atherosclerosis. I will not go through the course in details because Professor Ahmed Shawqi, the director of the course, will introduce to you the course, and after that Dr. Atif Al-Bahari will introduce the scientific agenda and some hints about also the course. Let me thank ICOM company for the technical support, and many thanks to Novartis for their non-restricted educational grant for this event or course. I think I can leave the mic now to Professor Ahmed Shawqi, the director of the project, to give you some hint about the 3 parts and the accreditation and everything. Dr. Shawqi, tfadl.
Thank you so much, Professor Ashraf. It's a pleasure having you all. Good evening to all the attendees all over the world who are watching us tonight. This is an important thing. We are going to look in a deep dive to heart failure with preserved ejection fraction. It's not going to be today only. It's going to be August 9th so far and 24th. Inshallah, as we say, hopefully these are the dates for the complete modules. There are going to be 3 modules. Today, we're going to talk about the epidemiology and clinical presentation of heart failure with preserved ejection fraction. Then, we're going to take on today about the pathophysiology of heart failure with preserved ejection fraction. Then, the next time is going to be an incredibly interesting one. We're going to talk about the diagnosis and pitfalls and the trials of the different mechanisms of management of heart failure with preserved ejection fraction. The 3rd module is going to be the last one, and we're going to discuss the different treatments of preserved ejection fraction heart failure, and finally, what the clinical guidelines say about heart failure with preserved ejection fraction. I remind you, this course is EBAC accredited. You're going to get credit hours if you go through the 3 modules and you answer the self-assessment questions at the end. Those who are not going to attend the 3 modules will have a certificate of attendance. But again, I remind you, make way for the credit hours, and it's a pleasure having you. Professor Atif, it's always lovely to see you.
Atif.
I can't make share. I don't know why.
Okay.
عايز اعمل شير ما بيعملش شير ليه؟ اوكي. Okay. Thank you very much, Professor Ashraf, Professor Ahmed. It's a pleasure to be a moderator for this very important course. Before all, I welcome everyone, everywhere, and I'm happy to moderate this session. The objective of HFpEF, if we have a course, as we know, for many years, it was difficult to convince clinicians that heart failure is present when the ejection fraction is normal. And this leads to, as we see here, this is a marked increase in the HFpEF that will cover by 65% of hospitalized heart failure patients will have of ejection fraction more than 40. And there is many questions about that. There is an increasing epidemic, a significant morbidity and mortality, lack of appropriate medical therapy, lack of understanding the pathophysiology, the multiple pathophysiology with common phenotype, and the expert with us, Professor Ashraf Ila, Professor Ahmed Shawqi, will answer the huge unmet need and the better understanding of the pathophysiologic needed, probably multiple pathophysiology leading to same disease phenotype. The personalized medicine may be needed to better understanding the issue on a given patient, and the deep phenotyping with biomarkers and advanced age. As we see here, we will uncover and clarify the definition, epidemiology, prognosis, the pathophysiology, the diagnostic criteria, and the scope of the new management in this course. I start first to introduce my dear colleague and my dear friend, the prestigious Professor Dr. Ashraf Reda, Professor of Cardiology and the President of EAVA, will handle the epidemiology and the clinical presentation, which will be followed by a discussion. And then we will continue with Professor Ahmed Shawi, Professor of Cardiology, and it will be the pathophysiology and comorbidities of PEF. First of all, I thank you and I introduce Professor Ashraf Reda.
Okay, thank you, Atif, and let me now take 30 seconds for break and stay with us to start the program. Well, thank you, Dr. Atif, and welcome you again, dear colleagues and participants. I think thanks to this webinar, you can take your coffee and maybe sitting on your relaxed on the couch and attending any scientific program all over the world, and this is actually marvelous thing. So let me speak something about the HFpEF epidemiology and the clinical presentations. Let us first start with the definition of HFpEF. The definition is very important. We want to know what the meaning of heart failure. For example, if you are talking about heart failure in general, whether HFpEF, whether HFrEF, reduced ejection fraction, or any other types, heart failure is a clinical syndrome. Heart failure is not an imaging diagnosis. There must be symptoms and signs. So by definition of heart failure, we mean the inability to provide adequate cardiac output to the body at rest or with exertion. Or sometimes this important cardiac output may be adequately provided, but at expense of increased elevated cardiac filling pressures. In these situations, you will notice of course, you will not measure the left ventricular end-diastolic pressure, but maybe in the echo, for example, you can notice left atrial enlargement, and left atrial enlargement is a sign of the abnormal filling pressure. So heart failure is an inability to provide adequate cardiac output. This is the main. But on one condition, there must be symptoms and signs. So clinically, it is very important to know that heart failure is a clinical syndrome. There must be some short of breath, fatigue, and edema caused by structural abnormality in the heart. So this is heart failure in general, whatever the type of heart failure. But the question here is, where do we draw the line between HFpEF, HFrEF, and even HF mid-range ejection fraction? There must be lines to discriminate between all these types. Let us look at the European Society of Cardiology Heart Failure Guidelines 2016. This table includes the criteria of reduced ejection fraction heart failure, mid-range ejection fraction heart failure, or sometimes called borderline, or preserved ejection fraction. Let us start with the end. Preserved ejection fraction. What is the normal ejection fraction? Normal ejection fraction is considered to be above 50%. So any ejection fraction above 50% will put you in this category. But you have to have symptoms and signs to diagnose heart failure. Whatever the heart failure, the name heart failure, the sentence heart failure means that there is symptoms and there is sign. There is clinical complaint of the patients. Without symptoms and signs, no heart failure. You can say diastolic dysfunction. You can say there may be reduced ejection fraction. But this is an imaging sentences, not a definition of heart failure. Heart failure is symptoms and signs. This is number one. Number two, look at the ejection fraction. If it is below 40%, then this is HFrEF. If it is above 50%, means normal, this is HFpEF. If it is in between, this is mid-range ejection fraction heart failure. Okay? There must be, or one of these elevated level of natriuretic peptide is very helpful in the diagnosis with at least one additional criteria. Either there is evidence of relevant structural heart disease, left ventricular hypertrophy, left atrial enlargement, or diastolic dysfunction. And I want to highlight here the importance of the fact that diastolic dysfunction in the echo does not mean diastolic heart failure, does not mean heart failure with preserved ejection fraction. Diastolic dysfunction is an echo data, an imaging data. If there is no short of breath, low cardiac output symptoms, edema, hypervolemia, this is heart failure. Okay, so you have to have symptoms and signs, then the ejection fraction, then biomarkers, and then one of these either relevant structural heart disease or presence of diastolic dysfunction. So the classification of the heart failure is in the presence of symptoms and signs, look at the ejection fraction to classify half ref, half PEF, preserved, or mid-range heart failure with ejection fraction in between. Previously, we were depending on the evaluation and diagnosis on the medical history, physical examination, chest X-ray, ECG, and standard lab. But this was really partially reliable. We need mechanisms to supplement this old way, and this is could be very helped done by the biomarkers and examining the biomarker. Biomarker in heart failure is important. It is not only in the diagnosis. It has actually a prognostic and diagnostic dimensions. The higher the biomarker, for example, the BNP or NT-proBNP, the higher the values, the poor the prognosis. And of course, when the diagnosis in doubt, there is some cutoff values that help in the diagnosis. It may even, this biomarker, have implications on the therapeutic options. Of course, the main, most widely used biomarker is the natriuretic peptide, which is BNP or NT-proBNP. However, there is many others biomarker related to fibrosis, related to inflammation, related to myocardial injury, even the remodeling. There is some biomarker for the remodeling, and nowadays they are talking about multi-marker approach in the diagnosis of cardiovascular disease. This is a nice diagram of the Japanese Heart Failure Society to telling you the cutoff values of the biomarker that help in the diagnosis of heart failure. Anyway, BNP above 40 or sometimes above 35 even, and NT-proBNP above 125 start here the possibility of the mild heart failure. However, if it is above 200 BNP or above 900 NT-proBNP, there is high possibility of heart failure that requires treatment. So this is some numbers regarding the cutoff value. So HFpEF or heart failure with preserved ejection fraction, we know that we now discuss the definition. We discussed some points in the diagnosis, whether clinical diagnosis, echo diagnosis, or use of biomarker. However, the important questions is this condition is prevalent? What is the prevalence of heart failure with preserved ejection fraction? Let us look at this program or project, Get With the Heart Failure Guidelines. This project actually has many papers, many published papers. This is one of them in the circulation 2012. Trends in patient hospitalized with heart failure preserved ejection fraction. Actually, more than 100,000 and 110,000 hospitalized patients with heart failure. Among them, 50% of these patients had heart failure with reduced ejection fraction. The usual heart failure you have, severe symptoms or signs, low ejection fraction below 40% or below 35%. So this is 50% of the case. 14% of the case had borderline ejection fraction. 36% of the patient, and this is very good, more than a third of these patients hospitalized for heart failure had heart failure with preserved ejection fraction. From 2005 to 2010, the proportion of hospitalization for heart failure preserved ejection patient increased from 33% to 39%. There is some data about the use of drug, especially ACE inhibitor and ARBs and beta blockers, and the trend toward increase or decrease in these drugs. Patients with heart failure preserved ejection fraction less frequently achieved the blood pressure control. And this is very important because hypertension is one of the important demographic data or risk factors that can contribute to have PEF or heart failure with preserved ejection fraction. Again, mortality of heart failure preserved ejection fraction is nearly similar, the same, and decreased from 3.3 in 2005 to 2.3 in 2010 with adjusted odds ratio. But this was stable for patients with heart failure with reduced ejection fraction, with no reduction like that noticed in HAF PEF. And this slide was presented by Dr. Atif from the same program, is Get With the Guidelines Heart Failure from 2005 to 2010. And as you notice, this is the prevalence of different types of heart failure according to the ejection fraction. This is with reduced ejection fraction, more than 50%. This is preserved ejection fraction, 35% approximately. And this is the mid-range ejection fraction. And it is really the trend showed increase among hospitalized patients with heart failure of the percentage of patients having heart failure with preserved ejection fraction. Even they expect, according to this algorithm, that by 2020, 65% of the hospitalized heart failure patient will have preserved ejection fraction above 40%. So the condition is really prevalent conditions, and it seems that even in the future it will be more prevalent. So we should look at this disease, understand the clinical picture, the diagnosis, the diagnostic criteria, the management strategies, and look at the clinical trial and the guidelines. This is another registry, optimized heart failure registry. More than 40,000 patients hospitalized for heart failure, and again, between 30 and 50% of all heart failure admission are with preserved ejection fraction again. So if you want me to give you small sentences about the prevalence, prevalence affects about 1% of 4-year-old individual. Actually, its prevalence sharply increased with age. It jumped to 10% in those over the age of 75. All in all, the prevalence is somewhere between 1.1% and 5.5% in the general population. This is again the diagram by Chang et al., published in the Circulation 2018, looking at the heart failure with preserved ejection fraction and the increasing of prevalence all over the years from 2005 to 2014. The black one is the total heart failure. It is increasing the prevalence. The red one is the reduced ejection fraction, and the blue one is one with preserved ejection fraction. And if you look at the black woman, white woman, black male, white male, it is more prevalent and more increasing progressively in black women and black men compared to white counterpart. I will not go through all this study, but I want to tell you that a lot of data present about the demographic characteristic and risk factor of HFpEF, heart failure, and this is very important because we want to know what is the risk factor contributing to what is the demographic characteristics of the patient having heart failure with preserved ejection fraction. If there is any criteria that can help us in putting a therapeutic strategy or diagnostic strategy. If we look at this excellent Swedish heart failure registry, looking at many parameters and the contribution for different types of heart failure: reduced ejection fraction, preserved ejection fraction, mid-range ejection fraction. This is the blue square is heart failure with preserved ejection fraction. So, for example, for the age, for each 10 years increase of age in favor of heart failure with preserved ejection fraction. Also, the higher the systolic blood pressure favor the presence of heart failure preserved ejection fraction. Presence of diabetes, the atrial fibrillation, lung disease, anemia, and the use of diuretics in the treatment. And if you want one sentence for that, it's older hypertensive female with atrial fibrillation most probably will have heart failure with preserved ejection fraction. So this is important to know the demographic criteria and the risk factors that could be present in patients with heart failure with preserved ejection fraction. The North American Olmsted County showed the implication of obesity on heart failure with preserved ejection fraction compared with non-obese. So if you have non-obese, the black dots, all the black dots are non-obese patients with heart failure preserved ejection fraction. The red one here and there and all the diagrams are half ref or heart failure with obese guy with half PEF. So if you compare the non-obese with the obese regarding, for example, pulmonary capillary wedge pressure, both of them have half PEF, heart failure preserved ejection fraction. But if you are obese with half PEF, you will have more higher pulmonary capillary wedge pressure. The right ventricular lung diameter will be more in the obese subjects, and the pulmonary artery pressure is more in the obese subjects with heart failure with preserved ejection fraction, and even the total heart volume is more in the obese patient compared to non-obese patient, despite both have half PEF or heart failure with preserved ejection fraction. If you look at the Paragon, especially at the global variation in heart failure present ejection fraction, according to the geographical and demographical distribution, because we have many types of heart failure with preserved ejection fraction according to the risk factors, according to the metabolic parameters. For example, in North America, the most common type is the metabolic type of HFpEF. What is the metabolic type? Obese, diabetic with coronary artery disease. In Western Europe, you have a type called elderly AF type. Elderly with AF, but there is no diabetes or obesity. In the Central Europe, it is the young coronary artery disease type. The age is young, there is obesity, and there is coronary artery disease. In South America, it is the young obese type. And from the title, the young, obese, no diabetes, no comorbidity burden. However, in Asia Pacific, it is the lean diabetic type. The only risk factor is diabetes, however, usually young and non-obese. So this is different types, globally may vary from country to country and from site to site. However, the definition is the same. Symptoms and signs. Symptoms and signs of heart failure. Ejection fraction preserved above 50%. Biochemical criteria. Okay? So the definition does not differ, but maybe the demographic characteristic, the associated risk factor is. So the clinical features of heart failure with preserved ejection fraction, it is the same as heart failure with reduced ejection fraction. You will have edema, orthopnea, paroxysmal nocturnal dyspnea, rest dyspnea, crackles, high GVP. However, for the S3 gallop, it is less prevalent in patients with half PEF compared to half ref or reduced ejection fraction, and also cardiomegaly is there, but it is less than heart failure with reduced ejection fraction. Regarding the mortality for hospitalized patient with heart failure, preserved ejection fraction, actually astonishing is that morbidity, mortality is not so much difference from heart failure with reduced ejection fraction, and this is the time to death or heart failure hospitalization after first hospitalization, and this is a time to death heart failure hospitalization from the diagnosis. And as you see, this is the blue one is the low ejection fraction, and the red one is the preserved ejection fraction. So they are similar morbidity, similar mortality to heart failure with reduced ejection fraction. Heart failure hospitalization and mortality actually even higher in those with heart failure preserved ejection fraction compared with similar comorbidity but without the heart failure. For example, this is trials, Accord trial, Europa trial, Peace, Life, Hope, many comorbidity like high cardiovascular risk, like diabetes, like hypertension and all, but when heart failure preserved ejection fraction is present, the mortality, heart failure hospitalization is much, much more compared to this event. So my take-home message, dear colleagues and participants, heart failure preserved ejection fraction or HFpEF is not a rare condition. Its prevalence is increasing worldwide due to the aging population. As we mentioned, it jumps to about 10% in those above the age of 75. It presents with symptoms and signs similar to heart failure with reduced ejection fraction. Why? Because this is heart failure. And as I told you, heart failure is a clinical syndrome. Heart failure is the symptoms and signs. And the mortality even in hospitalized HFpEF patient is not uncommon. Thank you. And I will leave the mic for Dr. Atif Al-Bahari to moderate some discussion if there.
Thank you very much, Professor Ashraf, for your prestigious lecture. And I wonder, it's HFpEF is like a basket full of mango, figs, dates, grapes, and they call it fruits. They have different shape, they have different colors, they have different taste, and they have different structure. So it's a wonderful title to have all these patients. And I have a question for you. Should ejection fraction of 55% to 65% be once again considered normal despite a patient's heart failure symptoms and signs exist?
This is very important, and actually this is one of the points that I want to highlight, and I try to highlight it in the slides many times. Actually, heart failure is a clinical syndrome. There must be symptoms and signs, whatever the ejection fraction is. So even if the ejection fraction is normal and the patient has symptoms of heart failure, you should do the workup and complete your workup to confirm the diagnosis by biomarkers, for example, other criteria of the diagnosis. Presence of left atrial abnormalities sometimes or left ventricular hypertrophy is the hallmark of the structural heart disease present in addition to the symptoms, and you can expect heart failure with preserved ejection fraction. So ejection fraction is important, but however, it does not exclude the presence of heart failure.
Okay, I come to the next question to you, Ashraf. In your experience, which of the following conditions can be the most easily confused with HFpEF when making a diagnosis of HFpEF? Is it COPD, pulmonary arterial hypertension, right heart failure, left-sided valvular heart disease, obesity, hypertensive-related left ventricular hypertrophy, diabetes, as we see from the global studies in your slides?
Okay, anyway, I think if we are talking about our clinical practice, I think the most difficult part is when we have a guy about 50 or 60 years old and complaining of short of breath, whatever the cause of short of breath, even if the cause by the end of the day is chronic bronchitis, even if the cause is just obesity and low physical activity. But if there is, whenever there is short of breath or easy fatigability, this is a problem. because in the aging population, the prevalence of HFpEF is high. And even you send him to do an echo, and the echo is normal ejection fraction. So actually, the most difficult part for me is presence of shorten of breath, whatever the reason. And of course, the most important of them is the cor pulmonale, because you know this patient is complaining of dyspnea, maybe orthopnea all the times, and it is clear that he has some wheezes and he have bronchitis. However, this does not mean that he does not have heart failure with preserved ejection fraction, and maybe he need some specific treatment that can help him.
You mentioned the left atrium is very important.
Yeah.
When doing the echocardiography, not depending only on the ejection fraction, there are other parameters in the diagnosis. How do you focus on the left atrium?
Actually, the importance of left atrium that well, let us remember again the definition of heart failure. Heart failure is the inability of the heart to produce adequate cardiac output, leading to symptoms and signs of heart failure due to high left ventricular end diastolic pressure. So how do we know that your patient have one of the consequence of high left ventricular end diastolic pressure is the enlargement of the left atrium. So maybe enlargement of the left atrium, maybe the hallmark that presence as a clue for the diagnosis that this patient have high left ventricular end diastolic pressure. Ejection fraction is normal, and the patient has symptoms, and the BNP biomarker is high. This is heart failure with preserved ejection fraction. So left atrial abnormality, and I think again, even left atrial abnormality is correlated with the age of the patient. The higher the age, the higher the left atrial abnormality, and this is go with the diagnosis of HFpEF, heart failure with preserved ejection fraction.
Do you like to ask a question, Professor Ahmed, or to Mr. Ashraf? Because now I'm looking for the audience to have some questions, but
Okay. Professor Ashraf, thank you so much for your introduction and this preliminary lecture. So I want to reiterate what you said, that heart failure with preserved ejection fraction is a dangerous disease. It is prevalent, and signs and symptoms are also equivalent with heart failure with reduced ejection fraction. It's not something that is asymptomatic, right, Dr. Ashraf?
Sure. Well, this is very important, because sometimes when you find an echo diastolic dysfunction, and one say this diastolic dysfunction, he rush in the diagnosis of HFpEF. But the word heart failure is symptoms.
Okay.
Heart failure means there is symptoms and signs of heart failure.
Okay, I have a question from an audience. What I understand is the PNP in both HFrEF and HFpEF are the same?
BNP is one of the important clue to the diagnosis of heart failure, whatever the type of heart failure is. It is mainly related to the increase in left ventricular end diastolic pressure. Of course, those with HFrEF and the huge heart has higher BNP level. However, it is related mainly to the low cardiac output and high left ventricular end diastolic pressure, and the presence of structural heart disease affecting the myocardium. It is one of the compensatory mechanisms for heart failure. So whenever there is low cardiac output, whenever there is high end diastolic pressure, you need a compensatory mechanism, and this is important, one of the important compensatory mechanisms to help the heart in this situation.
Okay.
Can I add something? Can I add something?
Yes, sure. Yes.
The audience are really jumping. I tell you, next time there will be an explanation for all BNP levels, whether this patient has atrial fibrillation, is a chronic heart failure patient, or an acute survivor of heart failure. The audience wants to know, and this shows us that we are successful. We are going to be successful in this meeting, and it's going to be a great meeting. Thank you all for your questions.
I think we can take a 30-second break.
Yes.
Okay, no.
And
Stay with us.
okay.
Okay.
It's a pleasure having this module of heart failure with preserved ejection fraction. It was preceded by an elegant presentation by Professor Ashraf Reda and moderated by an elegant professor, Professor Atif Al-Bahari. It's always a pleasure being part of this. But the pathophysiology and comorbidities are really important in our patients. Whether these patients are hypertensive, heart failure, diabetic, this is quite important. And we're going to take a look on this because understanding the management or understanding the disease, we should understand how it goes. We've seen this with heart failure with reduced ejection fraction. There is an improvement of outcomes because we understood the pathophysiology that includes the renin-angiotensin-aldosterone system. The advent of the natriuretic peptide system, this led to the sacubitril valsartan and how it improved morbidity and mortality in heart failure with reduced ejection fraction. But heart failure with a preserved ejection fraction is not only a new term, it's also a difficult term because we are not absolutely sure what is going on in this disease entity. So let's start with the pathophysiology. Actually, it's really complex. It's not so simple to give an idea and say every patient in heart failure with preserved ejection fraction is the same. And this is why we see a lot of different phenotypes of heart failure with preserved ejection fraction, a lot of different results in management of heart failure with preserved ejection fraction, a lot of different results in the trials of heart failure with preserved ejection fraction. But there are a lot to be put which are overlapped, like obesity. And obesity increases the plasma volume, the filling pressure. Obesity increases the inflammation. There's arterial stiffening, and this is why heart failure with preserved ejection fraction is commoner or being very common right now, like Professor Ashraf just told us. Above the age of 70, it's extremely common. You shouldn't leave the patient if he's symptomatic. Cardiometabolic comorbidities with increased ventricular stiffening, thus the myocardium becomes less efficient and the exercise capacity. And we remind you, the NIHA classification for limitation during exercise relates to both heart failure with reduced and preserved ejection fraction. The less exercise capacity you have, the worse the prognosis and the worse the mortality. Thus, exercise capacity improvement in heart failure with reduced or preserved ejection fraction improves outcomes, improves morbidity, improves mortality. Also, myocardial ischemia. If this is a patient with ischemia, not all patients with ischemia have a depressed ejection fraction, but they are symptomatic, even if they don't have any residual ischemia. So actually, phenotypes of heart failure with preserved ejection fraction are so many, are so different, are so heterogeneous. So we can call it a constellation of risks and comorbidities. And this is just on the left, you can see from the European Society guidelines, one of the most important is the age, hypertension, and atrial fibrillation. The female gender, again, a consistent risk seen in females more than males. Why? So far, there's no really accurate explanation. Is it the obesity that increases with the increasing age in females more than males? Is it different or hormones, different in the structures? We cannot really tell. But again, other risks that are accompanying heart failure with reduced ejection fraction are seen, like the metabolic syndrome, obesity, even pulmonary disease is a confounding diagnosis of heart failure with preserved ejection fraction, and it's a risk for heart failure with preserved ejection fraction. What goes on? There is dysfunction of the ventricles, not in the systolic manner, but in the relaxation and filling. The atrium itself is stunned or dysfunction. A little of autonomic or chronotropic incompetence. The vascular stiffening, again, remind yourself, age increases vascular stiffening and dysfunction. And this increases the afterload, and this can cause a really big, important outcome for patients with hypertension and heart failure with preserved ejection fraction. And a lot of the times, this elevated blood pressure and vascular stiffening was thought that heart failure with a preserved ejection fraction, which used to be called diastolic heart failure, is similar as hypertension. Actually, there are two different entities, and in the coming modules, you'll understand how to diagnose them accurately and differentiate them. Also, if we have valvular problems, not all valvular problems really reduce the ejection fraction. If you have an aortic regurgitation or a significant mitral regurgitation, you have hyperfunction of the ventricle actually, but the patient is symptomatic. The patient can become congested, and this is another entity of heart failure with preserved ejection fraction. So actually, it's different. On the left, you can see heart failure with reduced ejection fraction with the cardiac remodeling and the neurohormonal activation. And that is why, with renin-angiotensin aldosterone system antagonists and sympathetic beta blockers especially, not all of them, of course, there is an improved outcome with reduced ejection fraction. And with the advent of the natriuretic peptides, sacubitril valsartan was a game changer in this entity, which is heart failure with reduced ejection fraction. But preserved ejection fraction is really different. There are so many comorbidities intermingling with risks, intermingling with pathophysiologies, and this is why not all data show the improvement of outcomes with renin-angiotensin aldosterone system inhibitors or beta blockers. So you should understand that this is not a cardiac disorder primarily. This is mainly a systemic disorder with cardiac affection. And there are so many potential mechanisms. You'll see potential possible with heart failure with preserved ejection fraction. Could it be the dysfunctional calcium handling? Could it be abnormalities in the spring-like titin protein? And you can read a lot of papers about this. I'm just giving you an idea how scientists are thinking of heart failure with preserved ejection fraction. The myocardial cyclic GMP and how it is affected in heart failure with preserved ejection fraction, and some fibrosis, whether extracellular with reduced ventricular compliance and thus a shift in the contractility efficacy of the ventricle and dysfunction of the atria, which occurs in heart failure with preserved ejection fraction. Or is it also an inflammatory disease? Why is we're postulating that? Because we see it a lot in the metabolic syndrome, be it obesity, hypertension, and type 2 diabetes, which lead, as we know, to systemic inflammation. And this multi-organ affection increases the reactive oxygen species. And this reduces nitric oxide, cyclic GMP, and this leads to hypertrophy of the myocyte and stiffness. So could it be inflammation? Could it be a diastolic dysfunction? Could it be just the symptoms of the comorbidities? It's a constellation of everything. So what are the comorbidities? First of all, what is a comorbidity? It is a concomitant, but usually unrelated pathological disease or disease process, usually used in epidemiology. It's not a direct cause of the disease, but it could be an unrelated pathological or disease process. We see risk factors. For example, in coronary artery disease, we see hypertension, diabetes, but comorbidities, like in heart failure, we can see diabetes, renal failure, anemia, and so and so. So this is an important definition you should understand. And the comorbidities we see, or the risk factors we see also in heart failure with preserved ejection fraction, it is usually older than in heart failure with a reduced ejection fraction. And this is just one data. I'll show you more and more data. Hypertension is a little bit more prevalent, but atrial fibrillation is quite common. And if you look, as we grow older, the incidence of hypertension, the incidence of atrial fibrillation increases with age. And Professor Atif's question was excellent. COPD, yes, it's more prevalent in heart failure with preserved ejection fraction. And believe it or not, in some data also anemia. So a lot of different risk factors and comorbidities. And these increase. As you increase your comorbidities, the mortality and the possibility of hospitalization and getting worse increases, regardless of the socioeconomic status, regardless of what is the cardiac morbidity. But if you look also on the trends, looking at 1980s till now, you might find that the severity of comorbidities, and this is the Danish registry that was published 4 years ago, shows that the severity is increasing by time. We thought that heart failure with preserved ejection fraction was a myth. No, it's true. And its comorbidity burden is increasing by time. Why is that? Because we're growing older. Why is that? Because we're treating myocardial infarction and hypertension better, so patients are living more. So the possibility of comorbidities being severe is going on and on. Not only that, in a European registry, also the European Heart Failure Pilot Survey, showing that in most cases, or nearly 50%, there are two or more comorbidities intermingling in heart failure with preserved ejection fraction. Be it any of the comorbidities you see, chronic kidney disease, anemia, diabetes, COPD, they are intermingling and they are present in a lot. So a lot of the times, the patient does not have one, probably two or more comorbidities. Also, in Medicare patients in the United States, this was even much more advanced. There was 86% of patients having two or more comorbidities, and 25% actually had 6 or more comorbidities. So again, there is an interaction between a diastolic function, vascular problems. Also, there is an inflammation process and comorbidities with their problems, all ending up in the end of the drain, the heart, causing heart failure with preserved ejection fraction. If you look at data from registries comparing heart failure with reduced ejection fraction and preserved ejection fraction, consistently you find that the female gender is higher in preserved ejection fraction. A little bit of registry show a little bit more COPD in preserved ejection fraction, but others show an equal incidence. But always you see the female gender as being more prevalent in preserved ejection fraction heart failure. From community studies, again, consistent, there's the female. Maybe this is why Paragon heart failure with sacubitril valsartan showed a significant improvement in those with preserved ejection fraction in the female category. Maybe because they are more prevalent or more sicker, this could be it. COPD, a little bit more in the preserved ejection fraction with a little heterogeneity. And diabetes mellitus, it does both. Whether it's reduced or preserved, it is very common, and it usually ends up with preserved or reduced ejection fraction. Watch out, diabetic patients, more than 70% of them have some sort of heart failure, whether preserved, whether reduced. And this impact is important because if you do not look for the comorbidities and the risk, you should understand you're overlooking a very important point. Because if patients have a lot of comorbidities, their hospitalization rates increase markedly. And this is data seen maybe 17 years ago. And actually then heart failure with preserved ejection fraction was like a myth, systolic dysfunction or diastolic dysfunction. 90% of hospitalized patients were hospitalized if they had 9 or more comorbidities. And if patients did not have any comorbidities, at least a third of them were hospitalized annually. And we know hospitalization in heart failure increases morbidity, increases mortality, and is the most expensive health burden or economic burden on any healthcare service. Also, data showing this, that increasing comorbidities reduces survival, increases mortality. And this is data also published 2 years ago in the European Heart Journal. So as we see, diabetes increases mortality and morbidity of heart failure, whether reduced or preserved. And again, if you have a diabetic patient, 70% of the time, he's going to have either one. So you have to diagnose them. So keep tuned to the next module and they'll show you how to diagnose them accurately. Anemia. A lot of talk about anemia and reduced ejection fraction, but as also preserved ejection fraction, anemia increases the problems with preserved ejection fraction. And it is very common with preserved ejection fraction. Renal failure or chronic kidney disease increases morbidity and mortality in both reduced ejection fraction and preserved ejection fraction. And so COPD, and a little bit of data more with preserved ejection fraction being more prevalent with COPD patients. But one of the things I would like to highlight upon, like Professor Ashraf was talking about, is in the Western countries and our country, Egypt, of course, we have a lot of problem with obesity. And obesity has a lot of intermingling pathophysiologies, including a pro-inflammatory state. And this pro-inflammatory state can cause endothelial dysfunction, cardiomyocyte dysfunction, and hypoxia, which increases fibrosis, left ventricular wall stress, and the left ventricular filling pressures, even though the ejection fraction is normal. There goes, and then heart failure occurs. Of course, it can also affect the pericardium, causing RV failure, increasing pulmonary arterial hypertension. And this is another problem with obesity. And also, not to take in consideration that obesity increases hypertension, increases diabetes, increases metabolic syndrome, and these also add to the burden more and more. So why are we talking about comorbidities with heart failure? Because treatment of a comorbidity may in fact influence the heart failure prognosis. Like, let's say, non-steroidals in arthritis. Taking these medications for a long time probably will have a problem on impact on the heart. Beta agonists on COPD patients, they might have a deleterious effect. Treating heart failure by treating non-cardiac comorbidities is important because they improve the outcome. Treatment of heart failure may affect the comorbidity, like the RAS system inhibitors may affect the kidney disease and cause hyperkalemia, and the beta blockers may affect the lungs through COPD. So if you want to take a look, chronic obstructive airway disease mainly causes inflammation, parenchymal changes, and airflow limitation. This leads to pulmonary congestion, and this, look at this, leads to left ventricular diastolic filling disorders. So this is important. Also, the inhaled beta agonist may have cardiovascular events. Anemia causes adverse LV remodeling, definitely, and it causes and helps both preserved and reduced ejection fraction. It adverse cardiorenal effects and increased neurohormonal and inflammatory cytokines. Diabetes, again, I reiterate, 70% of diabetics will have some sort of heart failure, whether reduced, whether preserved. Diabetic cardiomyopathy, which has many mechanisms through mitochondrial dysfunction, abnormal calcium mechanism handling, oxidative stress, and activation of the renin-angiotensin-aldosterone system, regardless of the other causes, which is atherosclerosis and coronary artery disease. Renal dysfunction and chronic kidney disease with the sodium and fluid retention, it causes anemia. Patients with renal failure have anemia. Inflammation and also renin-angiotensin-aldosterone system and sympathetic activation. Sleep disorder, breathing, and obesity, interrelated, causing mainly systemic inflammation and sympathetic activation. This leads to arrhythmias, hypertension, and these two really have an impact on heart failure with preserved ejection fraction. So it is multifactorial. The vascular dysfunction, diastolic dysfunction, then go into systolic if not treated well. Neurohormonal changes, atrial and pulmonary and RV compromise also occur in heart failure with preserved ejection fraction, with an impact, a huge impact from the comorbidities and the pro-inflammatory state, and thus causing systemic alterations. This is why heart failure with preserved ejection fraction is multi-mechanistic, is very heterogeneous, includes a lot of system affections, includes a lot of mechanisms of action. And this is why a lot is trying and being invested in trying to manage these patients. Because as Professor Ashraf said, they are being more common right now than those with reduced ejection fraction. And just to give an idea on how this plays out, if you're looking at an obesity, we have to think about caloric restriction and exercise. Do they improve heart failure with preserved ejection fraction? Probably yes. Diabetes and the data on the new anti-diabetics and the SGLT2s, again, we don't know. Kidney dysfunction, and maybe if we give ACE inhibitors and ARBs and sacubitril valsartan, maybe this also improves. Improving patients with ischemia, iron deficiency, and iron supplementation, may this produce a better outcome in heart failure with preserved ejection fraction? Yes. How about pulmonary hypertension? And yes, there are trials on cyclic guanylate cyclase stimulators, and we'll discuss this and we'll see this in the next module, and phosphodiesterase inhibitors and prostaglandin derivatives. Treatment of hypertension, of course, treatment of hypertension is paramount in all patients, especially in heart failure with preserved ejection fraction. So does this actually lead to a better outcome in heart failure with preserved ejection fraction? We'll have to wait and listen and see what is going on and what is going on in these modules. So my take-home message is this heart failure with preserved ejection fraction is a complex heterogeneous disease. It shows interaction with a lot of comorbidities and pathophysiologies, inflammatory and non-inflammatory, direct and indirect. Comorbidities play an integral role, not only in the presentation, but also in the management strategy of heart failure with preserved ejection fraction. And until now, the main aspect of the guidelines, and this is going to be seen also in the third module of this series, is how the guidelines still now say that the most important part is managing these comorbidities. And I thank you again and wishing you any questions. We're here.
Thank you very much, dear Ahmed, for your skillful and prestigious lecture.
Thank you.
Can I have a question for you?
Please.
In your clinical experience, what are the proposed HFpEF phenotypes going to distinct treatment approaches?
Oh, this is a very good question. And I think we can have a discussion with Professor Ashraf
Yes.
if we like this. Yes. Like, for example, a COPD, very common in heart failure with preserved and reduced. But usually reduced causes congestion, and COPD usually causes preserved ejection fraction. And a lot of the times, these patients are treated through a chest physiologist or a chest physician, or a general practitioner or an internal medicine doctor, and they're trying to give beta agonists, they're trying to give bronchodilators, but the patient is not improving, and they tell us, we don't know. So they send it to the cardiology. Actually, a lot of these patients are heart failure with preserved ejection fraction. Do you see this a lot, Professor Ashraf, too?
Yeah, sure. And as you explain, excellent, that comorbidity and risk factors, it seems that they are the cornerstone in assessment of the patient and in our therapeutic strategy. And actually, I want to ask you questions about this in this area. I don't know whether it will be answered in next modules or not, because many of these comorbidities can lead to increase in the biomarker, like BNP and pro-BNP. So is it important to diagnose that an obese hypertensive patients have, in addition to obesity and hypertension, have PEF or heart failure with preserved ejection fraction, or it is just, it's okay, he is obese and he's hypertensive, I will manage the obesity and I will manage the hypertension, and there is no specific treatments or specific diagnostic tools? How can we solve this puzzle?
A very good question. And this is what we are trying to do through these modules. If I have an obese hypertensive, so what? He has HFpEF. I'm just going to give him the same treatment. No, you have to follow up. And you have to follow up the patient more diligently. You have to do a correct echo. It's not just diastolic dysfunction. It's E over E prime. And there are data. I'm not going to try to burn what's going to be said next time. There are different diagnostic modules, techniques, and you have to do the BNP. And according to yes, obesity does affect the BNP levels, does affect other things. But you are going to keep the patient under closer observation, stricter control, and you're going to try all lifestyle modifications to help. And if there is any update, you are going to be sticking to any news on heart failure with preserved ejection fraction to help your patients better.
Okay. Atif?
Okay, another question. We have many comorbidities with HFpEF. And these comorbidities, we should target our aim of treatment from the beginning for these comorbidities. But at the end, what do you think the causes of death in HFpEF? Is it cardiovascular or non-cardiovascular? And if you have some figures, you can mention it.
Okay. I have to quote that I got the figures from Professor Atif. He's the one who gave me the figures. So he knows a lot about data and figures. So really, actually, yes, cardiovascular death is the main cause of death in HFpEF. It's not hypertension. It's cardiovascular. Maybe 61% die because of cardiovascular death. And of them, 44% die because of sudden cardiac death. It is the same as HFrEF. Come on, guys, the people are dying from sudden cardiac death. This is why we should take care that this is not just a symptom for a disease. This is a deadly disease. 24% died due to heart failure, 14% due to stroke, and even 10% due to myocardial infarction. So actually, most of it is cardiovascular, and less and less, more and more, data is getting that patients die from sudden cardiac death, and medications that improve these outcomes might prove beneficial for the morbidity and mortality. And I have to quote Professor Atif's, he gave me the figures.
This fact about the high incidence of mortality due to sudden cardiac death and heart failure with preserved ejection fraction.
Yes, good question.
Is there any precaution or there any preventive measures?
A very good question. Again, we know that the data from the trials from the heart failure preserved ejection fraction, reduction of mortality has not been seen significantly, except maybe partially in the Paragon in females and in blacks. Maybe hospitalization was reduced with the charm and the candesartan in the charm preserved. But this is paving the way. I'm not trying to really stimulate the attendees, but there are extreme ideas on how to manage heart failure with preserved ejection fraction, including the pathophysiology that Professor Atif was alluding upon, cyclic GMP, phosphodiesterase inhibitors. There are even atrial shunting and other data to show, but definitely till now, there are trials on exercise improving morbidity and mortality. So actually, we are in a period of time that we have to first diagnose our patients, control the comorbidities, and maybe in the very near future, we might see data. I remind you, we are waiting for also SGLT2 inhibitor trials like dapagliflozin in the deliverer and empagliflozin in the preserved emperor. They might even prove beneficial. So the whole world is looking for heart failure with preserved ejection fraction.
We can
allow me, Atif, again, another questions if you...
yes, of course.
Allow me. Now if you look at the pathophysiology of any heart failure, it is related to the compensatory mechanism. And one of the important compensatory mechanisms is RAS activation of the RAS system and sympathetic nervous system. So in your opinion, why we don't have till now, as one can expect, that we get better with RAS inhibition or get better with beta blocker in patients with diastolic heart failure?
This is to me, sir?
Yeah.
Okay.
Yes.
We have marginal data on nebivolol, but believe it or not, beta blockers, atrial fibrillation and heart failure with preserved ejection fraction did not improve anything. RAS system inhibitors, most of them showed nothing except maybe candesartan in the charm preserved, reduction significant of heart failure hospitalization, but the mortality was not affected. But when talking about sacubitril valsartan, of course, we know the data for heart failure with reduced ejection fraction was incredible. The Paragon heart failure actually was positive in certain subsets. It was not positive if the ejection fraction it was above 63 or 57, but anybody below 57 was significantly improved. Females especially, blacks especially. So we're getting an idea. But there is also this idea that maybe the new drugs that we don't know how they work, the SGLT2 inhibitors of the anti-diabetic regimen, they might improve the outcomes. We're still waiting and we'll see.
Do you think
you can conclude out of this session?
You want to? Okay. So we can have 30 seconds
break.
So stay with us. I'd like to thank you, Professor Ashraf, Professor Ahmed, for your elegant and prestigious presentations. We know many things now about the epidemiology, the way of diagnosis, and the pathophysiology is very important, and the comorbidities that we have. This is the first episode of the PEF course of EAVA in PEF heart failure. The closing remarks here will be the overall burden of PEF is heavy and should be verified. We should understand it because it extends, and now the morbidity is very high and increasing. Hospitalization, we see it from the presentations, will be more than 60% of hospitalized patients. The outcomes for hospitalized patients are similar for patients with PEF and HFrEF. They are the same, but still the management is different in both. Why? We will see in the next episodes the management and the treatment, and we will discuss more and more for the standardized medications after the Paragon and after the studies that shows that we can change the ejection fraction that succeeded in females who have HFpEF to a range of 60% ejection fraction, while not males as a phenotype. A more standardized approach to diagnosis is very important, with a scoring system that we will explain in the next episode, and phenotyping are mandatory. So, as a conclusion, we learned the objective from episode 1. We have to wait for episode 2 and 3 to get the full information. And thank you again everybody. And thank you, Professor Ashraf, Professor Ahmed, for your presentations. Thank you.
Thank you, Atif. Thank you very much, Ahmed. And I think, Ahmed, you can give a hint to the participant now about the next episodes and the presentation assessment.
Okay, very important. Thank you, Professor Ashraf. Thank you, Professor Atif. We should, you're going to have go out and take self-assessment questions. Because if you want the EBAC certification, you have to do them. You have to listen to all modules. The next module, inshallah, it will be the 9th of August. We'll give you announcement before it, and it's going to be in a convenient time. We're going to talk about the trials of heart failure with preserved ejection fraction, and also the diagnosis. All the questions that you're asking about the left atrium, the biomarkers, and all of that will be answered in the next episode. So stay tuned, and hopefully you're going to enjoy this a lot.
Oh, thank you all. Thank you. See you in the next episode. Thank you. Bye.
Bye-bye.